Introduce yourself
If I introduce, okay.
and press the
Yeah, I'm
slide.
Dr. Swaleha Nadaf. I'm assistant professor in the Department of Neurology at Nair Hospital. And I've done my MBBS from Grant Medical College, JJ Hospital, MD from Grant Medical College, and DM from Nair Hospital in 2018. And since then, I've been assistant professor over there. Shall I start?
Yes, madam. Please start, madam.
Yeah. So,
Madam, slide.
hello.
PowerPoint,
Slideshow.
make it a slideshow, madam.
Okay. Now?
Yes, madam. Please carry on.
Okay. I just want a student, because I want this to be completely interactive. I don't want it to be a teaching session. So can students, any student can describe this diagram? They can unmute themselves and describe this. This is a simple basic diagram how the conductions happen in normal human beings. Hello?
The cross section of spinal cord with the anterior horn cells and posterior horns. From the anterior horn cells, the motor neuron, means the radical, comes. From the posterior horn, the sensory nerve root comes. Both join to form a spinal nerve. And then it comes to the peripheral nerve. It has both motor nerve and sensory nerve to the neuromuscular junction to the muscle.
Correct. So in a simpler way, whenever is a nerve conduction, we have to talk about afferent and efferent. Okay. So from the peripheral receptors, the sensations are carried by the sensory nerve. As you can see in this diagram, the sensory nerve first. Okay, so the sensations are carried through the sensory nerve. Then it reaches to the dorsal root ganglion, right? Then it goes to the dorsal root, which is again intraspinal. Okay. Then through the posterior horns, it enters into the spinal cord. Okay. And that there is a synapse over here. From there, anterior horn cells are there. From there, ventral roots will be there, ventral motor roots. Okay. And then it leaves and then it forms a single nerve, that is a peripheral nerve. Okay, which comes to the neuromuscular junction, and finally the conduction is relayed to the muscle. So this is the simple basic understanding of the nerve transmission. Okay. This is also another same diagram, that is sensory conductions are carried. It enters through the sensory root, dorsal root ganglion, and then sensory root, and then anterior horn cell, which comes out, ventral root, spinal nerve, which has a dorsal and ventral rami. So today we are going to discuss regarding the electrodiagnostic study. So what is the benefit of the doing like in a practical situation like this? All of the students must have seen the electrodiagnostic study happening. So what do you think is actually possible or help of this electrodiagnostic study? Can anybody answer that?
Localization.
What localization
severity
means?
And
localization means?
to see if it's a localization means if it's a postganglionic or
Very good.
Postganglionic or a preganglionic lesion. Or if it's an axonal demyelination.
Right. Your voice is
and
breaking.
Severity.
Yeah. Okay. So what she mentioned that with the help of electrodiagnostic study, we can localize, and we can localize to whether it is a postganglionic. What she told is correct. That is postganglionic or preganglionic structure is affected. Postganglion. What do you mean by ganglion? Which ganglion are you talking about?
Dorsal root ganglion.
Yeah, very good. So dorsal root ganglion, the structures beyond dorsal root ganglion are
Postganglionic.
correct. No, means what I want to say. What do you
Towards
mean
the
by
spinal cord is preganglionic, away from
spinal
the
cord?
dorsal root
Spinal
ganglion.
cord, yeah, anterior horn cells or ventral roots, they are the preganglionic structures in the LMN system. Okay, and anything beyond that will be a peripheral nerve. Everything is postganglionic. Okay, so we are able to localize the structure, whether it is a nerve or is it a brachial plexus or is it a neuromuscular junction or a muscle. Okay, and then also we get to know which fibers are affected, whether it is a sensory fiber affected, motor fiber affected, or a mixed neuropathy. It is sensory motor. And also most important, most what clinically I have realized, the most important thing is this axonal and demyelination. Okay, axonal neuropathies and demyelinating neuropathy. This is the most important use that I have in the clinical practice. And of course, we get to know whether it is a hyperacute or acute or subacute or a chronic element disease. Then also, of course, from the nerve conduction study, along with EMG, we can diagnose whether it's a ganglionopathy, whether it is a radiculopathy, whether it is a plexopathy, mononeuropathy, or polyneuropathy. Of course, by EMG and other structure and RNS helps for the neuromuscular junction. So nerve conduction study, usually for a short testing, if you have to study, it is distal nerve, which is median, ulnar, peroneal, and tibial nerves for motor, and sensory. For sensory, it is median, ulnar, radial, superficial, peroneal, and sural nerves. So motor conduction studies are technically less demanding. They don't require much of earthing. And that is why many times that is preferred before doing the sensory studies. But in literature, they have always suggested sensory to be done before CMAP study. Why is that?
If sensory is normal, peripheral nerve can be excluded mostly.
No, anything, any other reason? What is the normal voltage, normal current that is applied to study the sensory nerves? Hello?
Micro, less than the motor, microvolts.
Yeah, microvolts, but how much? No, we are talking about the responses are in microvolt, but when you're giving the current, that is in milliampere, right? Current is milliampere. Okay. So for the sensory, how much current is being given, and for motor, how much current is preferred? For sensory, usually you start from 10 or 15 milliamperes, and you go on escalating up to 30. Beyond 30, you are not supposed to give the current. And for CMAPs, it is like 50, say you can start. Understand? So whenever you do it directly a CMAP, you are directly giving 50 milliamperes to the current to the patient. So patient may just deny the further study. So you can always start with sensory first, go with the lower amperes, and then go on escalating and then study the CMAPs. Okay. Sensory snaps, motor conduction studies are technically less demanding. They are like measured in the ranges of voltage, that is millivolt for the CMAPs and microvolt for the snaps. Okay, and CMAPs are less affected by the other factors which can, like for example, electrical noise or technical factors, or earthing is not there proper. All these things, CMAPs don't get affected. That even ground is not working, CMAPs still come. But sensory snaps, you should be having a proper grounding. There should not be any artifactual things in the surrounding, and the ground should be properly kept. All these things. Okay. So CMAPs, the duration of current that is given is usually starting from 50 milliamperes, and the gain usually 2 to 5 millivolts per division. Okay, and duration of electric pulse is 200 microseconds. These things you should be understanding because these are technical things, and I'm hoping that you all have done physically the nerve conduction study, right? Okay. So this is how the electrode placement happens. Okay, for the CMAP study. So can anybody describe the why this is the way it is studied? Can anybody tell that? There is some physiology involved in it. See, this is the cathode end of the electrode. This is the anode end of the electrode. This is G1, that is the recording electrode, and this is the reference electrode G2. Okay, and the ground is kept in the behind the dorsum of the hand. So why this arrangement for the CMAP? Can anybody answer that? Like they can speak by unmuting themselves. Why is this arrangement there? This arrangement, this particular arrangement. I don't know the coloring that is there in your machines, but for us, the black one is the cathode and the red side is the anode. And even here, the G1 is black and G2 is red. So how does the current travel? Does it go from anode to cathode or cathode to anode? So the current usually travels from cathode to anode. Okay. Cathode is what? What is cathode and what is anode? Cathode is depolarization and anode is repolarization or hyperpolarization. Okay. So cathode is negative, right? Cathode is negative and the current is negative. So it travels from cathode to anode. Okay. So here what happens if you put a cathode over here and the anode is over here. If you put anode over here and the cathode over here, what is going to happen?
Anodal block.
Yeah, understood. So you have to always keep black to black. That is how we follow. Okay, so cathode to cathode you have to keep. Okay, so in median motor nerve study, recording the APB, stimulating the median nerve at the wrist is happening over here. In motor studies, the belly tendon method is used for the recording. Okay. So CMAP is usually biphasic potential. Motor conduction velocity can be calculated after stimulation of two sides, one distal and one proximal. Okay, and what are the parameters that are studied? That is one latency studied, amplitude is studied, area, duration, and conduction velocity. Okay, so this is the biphasic CMAP amplitude, CMAP record. So in this, what is the latency? What is amplitude, what is the duration, and what is the area?
The time taken for stimulus to reach the potential is the latency.
Is the latency, correct?
From the stimulus to the onset of the potential.
Yeah.
From base to
And
peak is the amplitude.
that is the amplitude. And then what is the duration? It
Duration
is the
is
first
between
deflection
the
to the
from the
yeah.
onset.
It is the it is the area. I mean, it is the, sorry, we are talking about duration. So it is a measure from the initial deflection from the baseline to the first baseline crossing that is happening here. Okay. So this is the duration. In addition, negative CMAP area, that is area above the baseline, is calculated by most मतलब अपना जो CMAP study होता है, that is, this is the negative. This is the peak, that is the negative, and this is positive. In the entire EMG and says this is negative and this is positive. Okay. So the importance of latency, it reflects the fastest conducting motor fibers. Okay. And amplitude is whatever the amplitude happens is because of the firing of the nerve fibers, all the nerve fibers giving rise to maximum peak, that is the amplitude. Okay. And duration is a measure of what? It is a measure of synchrony. So how many muscle fibers are acting together to give rise to a large amplitude, that is a duration. Okay. So if suppose some fibers are acting fast and some are slow, so the duration is going to increase. Understand? So that is what is the basic behind the duration. So time from stimulus to the initial deflection from baseline, it is latency. So latency considers three factors. Which are the three factors? That is the nerve conduction time from stimulus to the stimulus site to the neuromuscular junction, then time delay happening at the neuromuscular junction, and then the depolarization happening in the muscle. That much time is needed for the motor action potential. Correct? So that is the latency. It considers the nerve conduction time from stimulus site to the neuromuscular junction, then time spent at the neuromuscular junction, and then depolarization in the muscle. Then amplitude measures from baseline to first negative peak. Okay. It reflects the number of muscle fibers which are depolarizing at a time. Okay. Then when do we get low amplitude? When do we get low amplitude? Because of the axon loss. It can be seen in the conduction block from demyelination between the stimulation site and the recorded muscle, or it can happen in the neuromuscular junction disorders also and myopathies also, that amplitude, low amplitudes. Then what is the duration? It is measured from initial deflection from baseline to first baseline crossing. This is the initial deflection and this is the first baseline crossing. This is the duration. Okay. Then it is a measure of synchrony, means extent to which individual muscle fiber firing at the same time. So it's like all of the muscle fibers, if they are contracting at the same time, then it is going to be shorter duration. If they are not they are not firing at the same time, then different time happening, then the duration increases. That is why in demyelination, the duration increases, because in demyelination, there is a patchy conduction slowing. So if some fibers are firing very fast and other fibers are firing very slow, so that will increase the duration. So what is the conduction velocity? Can anybody tell what is conduction velocity?
Latency by time. Oh, sorry, distance by time.
Distance upon time. So basically, it is a measure of the speed of fastest conducting motor axons. It means it includes the conduction time along the distal motor axon to the neuromuscular junction. Then you again same thing, like neuromuscular junction time and then muscle depolarization time. Okay, so to calculate a true motor conduction velocity without this NMJ and muscle depolarization time, two stimulation sites has to be used. Understood? We have to suppose that is what it has to travel certain the calculation formula is distance upon time. Okay, so there has to be a distance, that means the length of fiber should be included, and then we have to calculate the time, but that time should not be between these two confounding factors, which are NMJ transmission time and muscle depolarization time. So what they're doing, for example, see, this is the distal stimulation site and this is the proximal stimulation site. Okay, so here you give a stimulus and there is a CMAP. Okay, and then here you give a stimulus and there is a delay and then there is a CMAP. Okay, so now what you are going to do, latency of this to minus, and the distance between the distal side and the proximal side you have to calculate by measuring tape, and you can put that value and you will get a conduction velocity. Okay, so for example, for median motor study, recording APP stimulating wrist and elbow. Okay, so here what we are discussing is this. This is the distance traveled by the electric potential, which is traveling from this latency to this latency. Okay, this is D. Then the time taken for the nerve conduction, I mean the nerve impulse and the muscle fiber contraction. Okay, that is traveling through the entire this nerve segment, and then neuromuscular junction, and then this is the muscle depolarization. Are you understanding what I'm trying to disclose? That this is a distal stimulation site. Okay, from here this much is the time taken to travel the impulse up to the neuromuscular junction, then the time spent in the neuromuscular junction, and then there is a muscle depolarization time. So these A, B, C are going to remain constant, more or less constant, not like 100% constant, but A, B, C they will remain more or less constants. So if you can just subtract the latency of this, and you keep the distance traveled from this to this latency, you will get a by that formula, that is distance traveled, that is D upon latency 1 minus latency 2, that is going to give you rise to conduction velocity. Okay, so conduction velocity reflects only the fastest fibers. Okay, so this is the measurement of conduction velocity. Then snaps, as most sensory responses are very small, that is 1 to 50 microvolts. Technical factors, electron, especially for snap, they get affected very easily because of the earthing issues or because of the technical issues. That is why they tend to be also very small. Why the sensory snaps are small?
Due to the phase cancellation and affect the only small fiber.
Very good. So in a sensory nerve, there are fibers which are like large fibers, and there is a lot of variation of fibers, nerve fibers. So there are large fibers with faster conduction velocities, and small fibers with a very slow conduction velocities, and both of them are acting together. So they are going to, I'll come back to that phase cancellation. So usually sensory responses are very small. And one more thing. So in CMAPs, you are stimulating the nerve and you are recording from the muscle. Okay, in SNAP, you are stimulating the nerve and you are recording also from the nerve. Which nerve? Cutaneous nerve.
Sural component.
Yeah, no, that is right. But if you are stimulating a sural nerve or you are stimulating a median nerve, you are stimulating the median nerve, but you are recording from the median nerve ka cutaneous nerve endings. Okay, but in sural nerve, it is direct nerve to nerve. Okay, and what is MNAP?
Mixed nerve action potential.
Mixed. What does it mean? Mixed means what? And what is the clinical? Where do we use it in clinically actually?
In mixed nerve conduction study, amplitude was large and is recorded from the tibial nerve, median nerve.
No, mixed nerve conduction study, MNAPs, in clinical situations, their amplitude tends to be very small. Okay, and they are deeply situated nerves usually when we are recording. Like you can check it in the plantar nerves, median and lateral plantar nerves, which we do for tarsal tunnel syndrome. That is a kind of a MNAP study. Understand, the amplitudes of the MNAPs are actually small, not very large. They are deeply situated. One reason is that. Okay, and another. Has anybody done this? Huh? Yeah, that is what I was talking about. So even tarsal tunnel and carpal tunnel, we use this MNAP studies actually. Okay. Then so snaps. So snaps could be biphasic or triphasic. Okay. So but CMAPs are usually biphasics. The gain should be kept around 10 to 20 microvolts. The duration of pulse, the duration to be given is 100. Usually we keep 100 microseconds. And current is usually in up, you can start from 5 to 10 milliamperes and you go on escalating to 30 milliamperes.
नीचे से भी कस रहा है ऊपर से भी कस रहा है ये मेरी सही एडवाइस है बाकी तुम्हें अगर ऐसे पहनने हैं बिकनी पहन के जाओ
Okay, so now electrode placement for snap. So this is also you are studying there are two different techniques. So one is this antidromic technique and one is orthodromic technique. So what is the difference between these two?
In the antidromic study, amplitude of SMAP is larger than the orthodromic.
No,
And,
but
is
what is
not,
like how it is done? That antidromic technique, how it is done?
in the antidromic technique, stimulating the wrist and recorded from the distal ring electrodes. In the orthodromic study, when stimulate from the finger and recorded from the wrist.
Correct. Very good. So, and because of this only, the antidromic amplitudes are usually smaller. Okay, and the orthodromic usually are larger. But which
No.
is actually, yeah.
Antidromic is larger. Orthodromic.
No. Antidromic tends to be smaller amplitudes because they have to travel a distance, no? They are near the receptors. Okay, antidromic are near the receptors. Remember that much.
Okay.
Okay. So ring here you can see this is an antidromic technique. So
Yes,
it is
ma'am.
near the receptor, right? So you are placing the electrodes over here, and then the ring electrodes are on the index finger. Okay, and you are stimulating. Okay, and it is stimulated at the wrist, and the cutaneous nerve fiber endings are recording the snap. Okay, so the snap amplitude, the snap usually tends to be biphasic or triphasic. The snap represents the summation of all underlying sensory fiber action potential. Okay, the onset latency, again the same thing. Onset latency is measured from the stimulus to the initial deflection, which is negative deflection. This is for biphasic snaps. And initial positive peak can happen in the triphasic. Positive means going down like this. So positive peak may happen for the triphasic snap. Onset latency represents nerve conduction time from stimulus site to the recording electrodes. Okay, stimulus site to the recording electrode, that is onset latency. And it is recording the time for the largest sensory nerve fibers. And sometimes you can also, some labs prefer peak latency rather than onset latency. Okay, so that is peak latency is measured from the initial stimulus to the midpoint of the first negative peak. Okay, and amplitude is measured from base to first negative peak. But you can also measure it from peak to peak, that is the negative peak midpoint and the positive peak midpoint. Okay, and the duration is measured from initial deflection. Duration is measured from initial deflection from baseline to the first baseline crossing. Correct. Only one stimulation site is required for calculating the sensory conduction velocity. Okay. So again here onset latency, peak latency is there, amplitude is there, then duration and conduction velocity. So antidromic, that is stimulating towards the receptor, and orthodromic is away from the sensory receptor. Okay, Antitromic better, sorry, the amplitude is tends to be slightly higher than the orthodromic. But what is the disadvantage? It is accompanied
Volume
by
conduction.
volume conducted by motor action potentials. Okay, because you are directly stimulating on the sensory, I mean the nerve, the associated motor also get activated, and because of that you can get false positive high amplitude reports. Okay, so that is the problem. So antidromic and orthodromic sensory nerve studies. So this is the median snap. So antidromic stimulation that we saw in the previous diagram, and 1 minute. Yeah. So in the bottom trace, you can see the orthodromic study, which is stimulating the index finger and recording is happening at the wrist. Okay. So the latency and conduction velocities tend to be identical for both. The antidromic method has the advantages of the higher amplitude snap, but it is followed by a large CMAP. See here, you can get a large CMAP, which is coming in a antidromic test. Okay, if the snap is absent in the antidromic study, care must be taken not to confuse the volume conducted motor potential as a snap potential. Okay, and note the difference between the duration between the snap and CMAP. It helps. Usually, how do you confuse? Sometimes, but if you see multiple reports, then you get to understand which is the snap and which is the CMAP. But duration is something which can help to differentiate between the snap and a CMAP. And snap is also sometimes triphasic. CMAP is never triphasic. Okay, so the duration between the snap and CMAP, it helps differentiate between the snap and the volume conducted motor action potential, which comes. Okay, so what is the nerve root lesion snaps versus CMAPs? So anatomical differences between the sensory and motor nerve fibers result in different patterns of nerve conduction abnormalities. Sensory nerve is derived from the dorsal root ganglion. Okay, so it's a bipolar cell whose central process, it's a bipolar cell. So the central process form that sensory root, and the distal process continues as a peripheral nerve fiber. And the motor nerve is derived from the anterior horn cell, which resides in the ventral gray matter of the spinal cord. And lesions of the nerve root separate the peripheral motor nerve from its neuron. They they leave the dorsal root ganglion and distal processes intact. So here the dorsal root ganglion remains intact. Therefore, the root lesions result in the degeneration of motor fibers distally, and abnormalities on the motor nerve conductions and EMG we can find. Okay, but the sensory will be always. So whenever you do an NCS, if you record the normal snap, that means the lesion is preganglionic, which is anterior horn cell versus roots. So what is this proximal stimulation, temporal dispersion, and phase cancellation? So this temporal dispersion and phase cancellation is more seen in the snap than the CMAP normally. Okay, within any sensory nerve, there are large, medium, and small fibers. They depolarize and fire at different rates. The slower fibers progressively lag behind the faster fibers. Hence, temporal dispersion is more common in the proximal stimulation. So hence with proximal stimulation, duration of snap increases, or CMAPs also increases, while the amplitude and the area decreases. We'll discuss that. So what is the phase cancellation? Can anybody describe phase cancellation? I'll put this diagram over here. Can anybody describe phase cancellation and temporal dispersion?
A negative wave is cancelled by the positive wave of the next wave, which is coming from the next nerve fiber. This is phase cancellation.
So no. Which negative wave, which positive wave? Kisme, you're talking about sensory or motor?
Means the subsequent sensory.
Yeah.
Means the slow conducting fibers.
Yeah.
The negative peak can be cancelled by the fast conducting fibers positive peak, which
Correct.
decreases its amplitude and increases
Yes.
in area.
Yeah. So sensory nerve action potentials and CMAPs both are compound potentials. Okay, representing the summation of individual sensory and muscle fiber action potentials. So there in each of these nerve fibers, there are fibers which are faster conducting, and then there are slower conducting fibers. Okay. So when you give a distal stimulation, the fast and slow fiber conductions, they arrive I mean, they arrive at they are stimulated at the same time. But with proximal stimulation, what happens? The slowest fiber, they are lagging behind the faster fibers. Okay. So that means the first, suppose large fiber has a positive initial negative deflection and then the positive deflection, and this the the larger fiber or the faster conducting fiber is already in its second half of the motor action potential, that is the trailing positive peak. Okay. And the the slower fibers, they are in the negative peak, so they are canceling each other, which is shown over here. Actually, this is the cancellation, that is a phase cancellation. So the positive peak of the fastest fiber, it's cancelling with the negative peak of the slow fiber, so that is giving rise to phase cancellation. And because of phase cancellation, what happens? Because of phase cancellation, there is decrease in the
amplitude.
amplitude and area also.
So increase.
Yeah. And increase in duration can happen. Increase in duration can happen.
Yes, ma'am.
Yeah. So the amplitude decreases, the
Area
area increases, and the
Duration
also increases. Okay. And this happens normally, this happens in the sensory, but doesn't happen that much in the motor fibers. Why?
Motor fiber is the fastest fiber and large fiber.
Yeah. So all of them will be acting simultaneously, and the phase cancellation doesn't happen that much in the motor fibers. Okay. Okay. So what is demyelination? What happens in the demyelination?
Conduction velocity decrease. Distal latency
Saltatory
increase.
conduction.
Latency prolongation. Conduction velocity slowing happens. And the amplitude, what happens to the amplitude?
Normal or
it can remain normal, or it can suddenly drop significantly, more than 50%.
More than 50%.
Yeah.
Then conduction
Okay.
blow.
Yeah. So a decreased conduction velocity, that is less than 75% of the lower limit of normal, and prolonged latency, that is more than 130% of upper limit of normal. So every lab has their cutoff values for the SNAPs and CMAPs. So if the latencies are prolonged than that, but you have to consider for the demyelination. Any conduction velocity which is slower than 35 in arms and 30 in the legs, it signifies the demyelination. Okay.
Demyelination.
But my issue is if suppose, for example, if the patient has diabetes for a long period of time, okay, and you see the nerve conduction study, okay, and now there is some latency prolongation, the axon, I mean the amplitude is also very low, and conduction velocities are around 30s. What you are going to report this as?
Axonal. Axonal.
Amplitudes are very low, so axonal.
Yeah, so amplitudes you have to first see. Okay, if the amplitude loss, for example, I'll give you an example. For example, this TBL conduction study you do, and the latency is suppose 6.1. Okay, and the amplitude is 1.1, and the conduction velocity is 30. What will you report this as?
Axonal.
Axonal.
Yeah, so first thing is that amplitude, so much amplitude loss doesn't happen in the demyelination. Okay, but if the conduction velocity is 20, what will you report this as? Or conduction velocity is 19, what will you report this as? Will you still say it is an axonal?
Axonal.
Will you still say it's an axonal, or
Yeah,
will you say
axonal.
something else?
Axonal.
Why?
Because of fiber loss.
Long-standing demyelination with axonal loss.
Yeah, I would say that. Why did you say that?
That is the usual case scenarios when the prolonged demyelination, the axonal flow is limited. So over the long term, the axonal loss also happens.
You are that is what actually already there is a long standing axonal degeneration of the nerves is going on, so there can be a secondary slowing of the secondary demyelination, we call it. Okay, so that can happen in the nerve fibers over a period of time. Okay, and the conduction velocity slows very low, so you can say that axonal with secondary demyelination, such reports. Okay, but if it is still 30s below 20, if it is going, then only you can say that. Okay, so conduction velocity near cutoff value, still you can call it as a demyelination. And the two important points to differentiate between inherited and acquired demyelinating neuropathies is
Conduction block.
Temporal.
In the acquired conduction block is more than 50%. Amplitude are decreased from the distal to the proximal. Yeah. And
most
in
important
the
thing is uniform slowing,
uniform slowing in inherited
yeah,
demyelinating neuropathy, no
Yeah.
more conduction block.
Yeah. So uniform slowing you should get in the inherited demyelinating neuropathies. And if the patchy slowing has happened, and then you are getting conduction blocks or temporal dispersions, more temporal dispersions, then it is indicative of acquired
Acquired.
demyelinating neuropathy.
Acquired.
Okay. Okay. So can anybody tell which are the inherited neuropathies, but with like abnormal conduction blocks?
HNP.
HNP.
Okay, and like in the sense multifocal inherited
Motor
neuropathy. Which is that? No. MMXCP nahi. Which is the multifocal demyelinating neuropathy? Multifocal in the sense ki it is happening in patching, it is not uniform. There are multiple conduction blocks, and then there is temporal dispersion also in happening in some fibers. No, I'm just asking simple things. There are some inherited neuropathies where you can get like that is a usual funda that you should get uniform slowing. But there are some uniform inherited neuropathies where you can get conduction blocks, and you can get multifocal kind of demyelination. HNPP you told, but there is one more, which is CMTX. Any other condition? In practical scenario, we have seen such cases that we have, like clinically, we are feeling that it's a inherited neuropathy. But if you see the NCS, you see that there is some conduction velocities in the range of 30s, some are in the 10, some are in 20s, and in some places you see conduction blocks also. So one is that CMTX, another is CMT1 with overlapping CIDP. Okay. There can be some inherited neuropathy where there can be overlapping demyelinating neuropathies also. Okay. So in those conditions also you can get this, mixed kind of picture. And then there is one more inherited neuropathy where you can get conduction block, which is that. That is CMT4. Okay, CMT4C especially. So these 3-4 things you should remember. Inherited neuropathy with conduction blocks or temporal dispersion. Okay. Then in the next session we will discuss this with case wise. So can anybody describe this figure? Yeah, anybody can describe this figure.
If
First,
demyelination,
second, third.
first is a demyelination is a distal to the distal and proximal stimulation site. Hence, both proximal distal amplitude are decreased. And second is a usual scenario where demyelination is between the distal and proximal stimulation site.
Correct.
Hence, proximal CMF amplitude is decreased more than 50%.
Correct.
Called as a conduction block. And
Correct.
third scenario, when demyelination is proximal to the distal and proximal stimulation site, when there are both normal and like
Yes.
it is slow.
Yeah, so in this situation, you can get normal CMAP amplitudes, both distally and proximally. Okay, so here you can have abnormalities in the F waves. Okay.
Yes, ma'am.
Yeah. So this is how we do the nerve conduction study. You put the electrodes and you try to, this is not inching, this is different. This is like from the optimal position, you go 0.5 centimeter medially and laterally, 1 centimeter medially and laterally, and try to see where you get the maximum amplitude. You go from the supramax, and then you go for the supramaxillary stimulation. Like you can start with 10 or 11 milliamperes. And then you try to find wherever you get the maximum amplitude, and then from that side you start increasing the current. Okay. Okay, so optimal stimulator position and supramaximal stimulation, that is what I have described just now. So what are the patterns of NCS abnormalities? Suppose this is the A. Okay, this is a normal study with the amplitude and the conduction velocity being normal. Distal latency and conduction velocities being normal. Now, what is happening in the second? It is the latencies are okay, but the amplitudes are very low and conduction velocities are normal. Then in the third case, what is happening? There is a significant prolongation of the latencies and there is significant slowing of the conduction velocities also. So this is a slowing, that is a demyelinating kind of neuropathy. And here what is happening is there is a conduction block between the distal and the proximal record, and the proximal stimulation goes very low amplitude. Okay. Now I come to this proximal and distal stimulation. So in the normal proximal and distal stimulation, what you should see in the nerve conduction study, normal. What happens to the proximal stimulation amplitude, latency, and area? If you stimulate a distal side, then you stimulate a proximal side. Yeah. Latency.
In the proximal stimulation, it increases, amplitude decreases.
Amplitude should be low in the proximal stimulation, right?
Yes.
Yes.
Yeah. So what if you are recording a median nerve, okay, and you get a higher proximal amplitude as compared to the distal? Then what is it? What is that?
There are the three possibilities. The first is the supramaximal stimulation is the proximal side, and substimulation is the distal side, or there is a Martin-Gubner anastomosis.
Very good, very good. So what is this Martin-Gruber anastomosis?
Is a median nerve fiber crossover to the ulnar nerve fiber and supply to the ulnar nerve muscle which supply to the ulnar nerve, like FDI, abductor digiti minimi, and flexor. Flexor pollicis brace.
Yeah, flexor pollicis brace. No, so what happens is there is a communication between the median nerve and ulnar nerve, right? So that communication can happen anywhere, but most of the times it is in the forearm.
Forearm.
Correct. Most of the time the communication that is supplying from the median to ulnar nerve is in the forearm.
Forearm, mid forearm.
So what happens because of that is some median nerve is supplying the ulnar innervated hand muscles, like for example FDI, then hypothenar. That can, what you have described is a different scenario. Okay, so there are different muscles getting stimulated from ulnar to median side. That is what is usually is seen. So sometimes what happens ki median nerve is supplying the ulnar innervated muscle, like intrinsic hand muscles, FDI, hypothenar muscles, and thenar muscles. So how will you identify that?
during the ulnar study, when the distal proximal CMAP amplitude is greater than the distal CMAP amplitude,
Hmm.
then
No. I am saying now that ulnar nerves are innervated by the ulnar muscles. Sorry, not nerve. Ulnar muscles are innervated by the median nerve. So how will you identify that? Ulnar innervated muscles.
during ulnar nerve study, we
Ah.
put the record of the median nerve at the wrist and cubital fossa. And if in the cubital fossa CMAP amplitude is more than the wrist and is likely equal to the CMAP amplitude drop from the distal to the proximal on ulnar nerve study.
Correct. So what happens is when you're stimulating the ulnar nerve, okay, you are getting a good CMAP. Okay, because both the muscles are being stimulated, correct? So when you are going proximally, it is now just pure ulnar nerve. Okay, so pure ulnar nerve innervated muscles are very small number. Okay, so that is why the CMAP amplitude goes significantly low at the proximal ulnar stimulation site. Correct, no?
Yes, ma'am.
Yeah. Okay. So how will you cross check if this is a Martin-Gruber anastomosis in this case? One thing is this ulnar ka proximal, but how will you say that this is a Martin-Gruber anastomosis in this case?
Then stimulate the median nerve at the wrist and antecubital fossa.
Correct. So what will you see then?
Then we see in the cubital fossa proximal stimulation of median nerve. So the larger CMAP amplitude than the distal.
Yes, correct.
And is exactly equal to the dropping of distal to the proximal ulnar nerve study.
Correct. So most important thing is dropping of amplitude from the distal to proximal in ulnar nerve study and proximal larger amplitude in median nerve study. Correct. So this is the way you can find out that this is a Martin-Gruber anastomosis. Okay.
Yes, ma'am.
Yeah. So which are other anastomosis that you are aware of?
Accessory peroneal now in the
Accessory
lower
deep
limb.
accessory deep peroneal anastomosis. Then any other?
Then one is a pure ulnar hand in a wall median muscle supplied by the ulnar nerve.
No, that is there is one more between the motor branch of median nerve and deep ulnar branch of ulnar nerve. Again, same like between the median and ulnar nerve, there is one more anastomosis that is called as Riche canyu anastomosis. Riche canyu. So in that, what happens? In that, again, the same thing, like ulnar innervated the smaller muscles like intraossei, then ADM, and also this thing, flexor digiti minimi. So all these are innervated by the median nerve. Okay.
Yes, ma'am.
That is called as Riche canyu anastomosis. Okay, so you should be aware of all the anastomosis, different types of anastomosis. But Martin-Gruber, you have to understand properly. Okay. Then, so what happens to the nerve conduction study if it's a neuromuscular junction disorder?
In the presynaptic, this is a low amplitude CMAP, not touch to the safety point.
Why is that?
Because
Presynaptic
there
means
is
you're
a not
talking
release.
about lens, no?
Lens
So why in the snaps? See, usually neuromuscular junction is diagnosed only on the repetitive nerve conduction study, but in the in NCS, what abnormalities you can see in the neuromuscular junction disorder that we are discussing. So over here, what you notice is that low initial amplitude of the in presynaptic disorder, the initial amplitude will be low, CMAP amplitude will be low. Okay, the conduction velocity and latency and all will be okay. Only the amplitude will be low. It's suggestive of axonopathy. Understand? And in the postsynaptic, the CMAP amplitude will be normal. Yeah. Any other nerve conduction study abnormalities you have noticed in the neuromuscular junction disorders?
Like RNS.
Not RNS. We are talking about NCS. NCS also can give some findings in the neuromuscular junction disorders.
Double CMAP.
Very good. What is double CMAP? And seen in which condition?
In slow channel. Slow
Slow channel congenital
myasthenia.
myasthenic syndromes. Slow channel congenital myasthenic syndromes. And what about what is after discharges? Is it same as double CMAP or something different? What is double CMAP?
Single stimulus.
Cholinesterase deficient.
No. What, like in the nerve conduction study, CMAP, what is
We
happening? in
see
that?
two peaks.
Yeah, the second peak is smaller or larger?
2 peaks. Second peak is larger.
No, it is smaller only. Second peak is smaller. Okay. And after discharges, sorry, the one which you said is double CMAP, and the after discharges are also again 2 CMAPs are coming, one after the another. But in double CMAP, the duration between the first and second CMAP is less, whereas in after discharges, the duration is more. Okay. The duration between the first and the second CMAP that is coming, that is high in the after discharges. And that also can be seen in the acquired also and the inherited congenital myasthenic syndrome also. Okay. So that is very non-specific. Any other okay, fine. Then we'll discuss NCS in myopathies. Usually it is distal myopathies, only CMAP can get low. Otherwise, sensory snaps and conduction velocity and everything is normal. Okay. And does anybody have any issues regarding nerve conduction study basics? Anyways, it was very difficult. You have to sit and read it properly, because to describe it is very difficult. Anything you want to discuss in the basic of the nerve conduction study?
If you have any doubts, you can post in the chat box, or
Can
you can
anybody
directly ask them.
describe? Yeah. Can anybody describe inching? I think that remained. What is inching?
It mainly used in the carpal tunnel syndrome technique.
No. It is not just carpal tunnel syndrome.
Yeah.
Just describe what is the, like, what do we do in inching?
We stimulation gradually in the distal direction, and where the CMAP amplitude is a drop significantly, then we know for the demyelination or block.
So you start from distal most site and you go proximally by 1 centimeter.
1
Okay. So at every 1 centimeter, you will check the latency, amplitude, and the latency and amplitude, and then conduction velocity also, as you go proximally. Okay. And then what do you notice? Like, for example, you at the peroneal region, in the peroneal area, you have stimulated the ulnar we'll discuss. So in the ulnar, usually we do it more for the ulnar. So you do it distally, stimulation you have done. Now you want to go like below elbow, you have to go at the elbow, and then you have to go to the above elbow, right?
Yes, ma'am.
Yeah. So in that also you can split it, like further 1 centimeter stimulations you can do. And then at the level of elbow, you find there is significant drop of the amplitude. Yeah. So that means there is conduction block happening in that region. That is what is inching. Okay. Yes. Then what should be the normal temperature when you are conducting the nerve conduction study?
33 degrees Celsius.
Yeah. So suppose if there is cooler temperature, what is going to happen?
Decrease the nerve conduction. Increase latency and decrease conduction velocity.
Yeah. So it looks like it's a false demyelinating disease because of the increase in the latency and decrease in the conduction velocity. Okay. And anything else? Anomalies we have discussed, right? Anybody has issue in the temporal dispersion and phase cancellation? Okay, then I'll go for the next one.
Madam, once examiner asked me what is the formula of conduction velocity, time
So
and
it is
distance.
distance upon time. So time is calculated by subtracting the latency of the proximal stimulation and the latency of the distal stimulation. So that is, I mean, the distal latency minus proximal latency, and the distance is the conduction velocity is equal to distance upon time. That much is the formula. And the time is calculated by subtracting the latency of the proximal stimulation and distal stimulation. Okay. Okay. And always remember, we give lower amplitude. Basic thing it is that lower current, lower milliamperes we use for the sensory, and higher milliamperes you are using for the motor conduction. And milliamperes means what I'm saying, ki the nerve conduction study, when it is performed, it is either constant current wala or it is constant amplitude voltage wala, not amplitude, constant voltage or constant current is there. So most of the nerve conduction studies that are happening in the labs are constant voltage. So you can change the current. Okay. So what we are changing on this stimulation is current. The basics of that nerve conduction study or the technicalities, they are difficult to understand, but you should know that you are changing the current. You are changing the sense. What is sensitivity? I discussed this in the initial slide. 1 minute. Here. So that how much duration you use for the motor and how much duration is used for the sensory, that also should be clear. Usually it is 200 for the motor and 100 for the sensory, and current is 50 milliamperes for the motor and less than 30 milliamperes for the snaps. And gain should be, we usually keep it as 5 millivolt for CMAPs, and for snaps it is
10 to 20 microvolt.
10 to 20 micro, it is microvolts. Okay. And the snap response is recorded in microvolt and CMAP response is recorded in millivolts.
Millivolt.
Yeah. Okay. Anything else? The current usually flows, current flows from cathode to anode, that is negative pole to positive pole. It doesn't go for, somebody has answered here, anode to cathode. So current flows from cathode to anode. Okay. And the cathode is a negative pole and anode is a positive pole. Okay. So then when you're stimulating, what you're doing exactly? And remember this, that cathode will be depolarizing and anode will be hyperpolarizing. Is this understood?
Yes, ma'am.
So that is like we are talking about the stimulating electrode. So it has one cathode which is negative and one anode that is positive. And the cathode, the current is going from cathode to anode. Okay. So cathode is causing depolarization and anode is causing hyperpolarization. And when you're recording, what you're going to keep? How you're going to keep?
Black to black, cathode to
Black to black. That is how we used to remember. So cathode is closer to the recording electrode. Recording electrode is usually black. So that is how we used to keep, like black to black. So cathode is kept near the recording electrode, which is black. That is how you should remember. Otherwise, if you keep the reference electrode first, there will be anodal block. That is called as anodal block. Understand? And then you can get a false
increased distal latency.
yeah, false increased distal latency, or sometimes you may not get any record only.
Record
Okay,
only.
that is the thing for the cathode to anode stimulation. Okay. I think we have covered. I think for nerve conduction study, this much basic is okay. Then we can go for the late responses. So what are the late responses? There are two late responses, F response and H reflex.
Reflex.
Why I have said F response and H
Because
reflex?
in F response no synapse. In
Yes.
the H reflex is a synapse present.
Yeah, F is it's not a reflex. There is no synapse involved in it. H is a reflex because there is a synapse involved in it. Okay. So both are usually thought of assessing the proximal segments of the nerve. Which are the proximal segments of the nerve? It is the roots and the anterior horn cell. Okay. And they are most useful when the routine nerve conduction study, especially distal segments, are normal and the late responses are abnormal. That gives a clue that the lesion is proximal. Okay. So F response is a late motor response which occurs after the CMAP potential. So those who have done the nerve conduction study, they will know initially first thing that comes is M.
M.
The first response is M, that is motor potential. And the next response is F. The F is coming from where? From foot. The name is coming from foot because it was first recorded from the intrinsic foot muscles. Okay. In the upper extremity, the F response occurs at latency of 25 to 32. This is the latency for upper limbs. And for lower limbs, the latency is usually 45 to 56 milliseconds. Okay. So the F response is derived by antidromic travel up the nerve to the anterior horn cell. I'll just show you a diagram. F response over here. So can anybody describe this F response? How the F response is coming? Without reading what is given below. Huh? Can anybody describe this?
From the stimulation, it's going orthodromically.
This S,
to
no?
the
This
anterior
S
horn
is the
cell.
stimulation. Somebody is telling.
From the stimulation, it is going to the anterior horn cells and then firing back to the muscle.
So what happens is when you give a stimulation by electrode, okay, first thing that fires is M. This is the either stimulation we have given. The current directly travels from here to here, from neuromuscular junction to muscle, and the first response comes, that is M. Okay. And
Yes,
then from the stimulation, ulta response goes, which is antidromic. This is orthodromic transmission, and this is ulta, that is antidromic transmission. Okay. So from the stimulation, the response goes back to the anterior horn cell, and then again comes back through the same nerve. Okay. And then it fires. So that is few muscle fibers are fired. Okay. So the F wave amplitude should be more, or M wave amplitude should be more?
M wave is more.
Yeah. Why?
Only few anterior horn cells.
Yeah, that is the thing. Only few anterior horn cells fire. So that is why the F wave amplitude is always lower than the M amplitude. Okay. And okay, so we'll go to characters of F waves. So F response is derived by the antidromic travel up the nerve to the anterior horn cell with backfiring of small population of anterior horn cells, and orthodromic travel back down the nerve past the stimulation site and ultimately to the muscle. So F response is small CMAP representing 1 to 5% of the muscle fibers. The F response circuitry, both afferent and efferent, is therefore pure motor. There is no reflex involved in this. That's why it's not a true reflex. It's a response. Each F response varies slightly in latency, configuration, and amplitude because a different population of anterior horn cell is activated with each stimulation. Presumably, the shortest latency represents the largest and fastest motor fibers. F wave persistence is a measure of number of F waves obtained per number of stimulation. Per number of stimulation is how many stimulations you do in one setting?
10.
Yeah. So in that 10 setting, हाँ.
5
So,
is
in one setting, you stimulate 10 times, okay? And the number of F wave present will be F wave persistence. Normal F wave persistence is 80 to 100%. That is always above 50%. But and F wave impersistence is seen in which condition?
any polyradicular.
ADP.
Yeah,
CIDP
AIDP. That is the earliest
CIDP.
earliest nerve conduction study abnormality in AIDP. That is F wave impersistence. Okay. F wave chronodispersion. That is the difference between the fastest and the maximal. That is
Maximum.
slowest F response. That is chronodispersion. Okay. The normal chronodispersion is up to 4 milliseconds in the upper extremities and up to 6 milliseconds in the lower extremities. Okay. Anything beyond that is like you can say that there is a chronodispersion in the F waves. Okay. So this is the initial M response and then there is this F response. So normal F response stimulating. Okay. I'll not describe this then. So here you have 10 records. One which is having the minimal latency and one which is having the maximum latency. Okay. So, and this chronodispersion, if beyond 6, then you can say that there is a significant chronodispersion. F response, 10 raster traces are taken. Minimal latency is the shortest of the 10 responses, representing the largest and fastest conducting fiber. Chronodispersion is the difference between the minimal and maximum latency of the F response. F wave persistence is the number of F response obtained per number of stimulations. Okay. In this case, F responses are absent in traces 4 and 10. But that means the persistence is still 80. It is 80%. Okay. Out of 10, 2 are absent. Okay. Then what is the clinical use of F response? It will indicate the proximal conduction issues like radiculopathies or plexopathies. Okay. Then we come to H reflex. H name comes from Hoffman. H response is distinctly different from the F response in that it is a true reflex with the sensory afferent. Then there is a synapse and then there is a motor efferent segment. Okay. The circuitry of the H reflex involves the type 1 and then you have to know the types of nerve fibers also. Okay, the afferent is 1A muscle spindle fiber, sensory afferent, and the alpha motor neurons are the efferent. Okay, can anybody tell me the types of nerve fibers? Very basic, but some examiners ask it.
Type 1, type 2, type 3, and in type 1, alpha, beta, gamma, delta.
Okay. Any other better classification? Or a detailed classification?
1A and 2 are from the muscle spindle. 1B is from the Golgi tendon organ.
Correct, but can anybody like elaborate? So there is one classification that is like uniformly followed that was given in Ganong. So you have sensory and motor and sensory only like that. Okay, and sensory motor, I'll just post that in the group. Okay, so you go through the types of fibers, nerve fibers. Some examiners like to ask that. Okay. And so H response is distinctly different from the F response in that it is a two reflex. There is a sensory and motor segment. The circuitry of H reflex involves the type A, 1A muscle spindle as afferent and the alpha motor neurons as the efferent. So can anybody describe this and in proper elaboration, because you all must have read H reflex by now. You don't need to read, just like proper understanding should be there. That's it.
In the first image, when we stimulate as a submaximal stimulus, only one sensory fiber is activate and reflex arc is formed by motor fiber, and only H reflex is present.
So this is
When
the
the
first
stimulation
diagram,
is
correct.
increased.
This is the first diagram. This is the first diagram, right? What you are describing. So here the stimulation is given. Is my this thing visible? This cursor that I'm moving?
Yes, ma'am.
So this is the stimulation given. Okay. Now some stimulation is going to go like this
Yes.
and come back like this. And some stimulation is going to go directly like this. Okay. So
No,
that is why when you are checking the H reflex, you always start sub-maximally.
Sub-maximum.
Understand? So you go very low amplitude. How much you start from? You must have done in the labs, no? So we usually start from 10 and we go to
10.
100. That we do. Not the 100, but we go up to at least 60. This thing.
50.
Okay. Yeah. And so we start first from 10 milliamperes. Okay. So because of this sub-maximum stimulation, only few fibers of get stimulated. That is type 1A sensory fibers. They go antidromically, they go through the sensory nerve root, ganglion, sensory nerve root, then they come to the spinal cord, then they stimulate the anterior horn cell, and then from there the response comes out and you get a contraction of muscle fiber, and then you get an H response. That is the submaximal stimulation. That is low intensity stimulation. Then what happens?
When stimulation is increased,
When
then both
you go
sensory
on
and motor
increasing
fiber
the
both are
stimulation. Yeah, correct. So when you go on increasing the stimulation, now you're giving stimulation, but now the current is higher. Okay. So now these are getting stimulated only. Okay. But there is another stimulation that is happening is direct from here to here. Correct?
Yes, ma'am.
Yeah. So here what happens that the typical direct stimulation happening from the stimulation side to the neuromuscular junction and muscle. So you get an M response. Okay. But the M response is still low because your current stimulation is still low and lower number of muscle fibers are getting stimulated. Okay. And H response is still big. Why the M response is still low?
Because it is not a supramaximal stimulation.
Yes, that is one thing. And one more thing.
Not phase cancellation.
And the H amplitude, which is there now, here it is the maximal H amplitude. Okay. Yes, then what happens later on? Now this is the third time. Okay. So you are stimulating with a supramaximal stimulation. Now what is happening is you are stimulating the fiber, which are also both the fibers are getting stimulated now. This the sensory fibers also and all the motor fibers also, because you are giving supramaximal stimulation. So now the sensory is taking the afferent, it is going back, then the response is coming, but the response is also happening over here. Understand? And the response will be bigger. Why? This response will be bigger and H will be smaller. Why?
Much phase
M response
cancellation
will be bigger. M response will be bigger amplitude and H response will be smaller amplitude. What is the reason of that?
Collision and phase
Yeah,
cancellation.
so this is the reason. There is a collision happening over here. So the response which is coming back, okay, it gets collided with the response which is there, which is going antidromically from the this side. Okay, they are clashing, and then there is decrease in the amplitude of the H response. Okay, that is what is the H reflex circuitry.
Yes, sir.
How do you are recording the H response?
Fifth and sixth part. We draw the line from the Achilles tendon to the popliteal fossa and divided it into 8 parts. And
Yes.
maximum record is a 5th to 6th part and
Yes.
stimulate in the popliteal fossa.
Correct. Very good. So this is the M response, then this is the H response. Okay. So the response is the electrical correlation of S1 ankle reflex. It is electrical correlate of the S1 tendon ankle reflex. If the ankle reflex is present clinically, and H reflex should be also present. If the ankle reflex is absent, usually H reflex also should be absent, but sometimes you can see H reflex being present. Okay. But for large this thing population, it is ankle absent, H reflex should be absent. Any lesion that might decrease the ankle reflex also should prolong or at least reduce, decrease or stop like absent H reflex. Okay, so you can see absent H reflex in polyneuropathies, in tibial and sciatic neuropathies, and you can see it absent in the S1 radiculopathies also. Okay, what is HM ratio? H reflex and M.
An amplitude of maximum H and maximum M.
M. Yeah, so that ratio, what is the significance? Usually for the anterior horn cells, they have described for this H and M ratio. Okay, anterior horn cell, how they are stimulable. So that ratio they have given a just cut off. I'll just see that and inform you. Okay, so H and M ratio we'll have to see. Then F response and H reflex. What is the difference? F response is motor is afferent and efferent is also motor. Synapse, there is not a synapse. The nerve studies, it is studied in all nerves. The stimulation is always supramaximal from the beginning. Configuration, it is usually polyphasic. The amplitude is 1% or 1 to 5% of CMAP amplitude, and it varies with each stimulation. The latency can be minimal to maximal. There can be chronodispersion and persistence of F waves we have to calculate. So F waves get affected in the GBS or radiculopathies, polyneuropathies, and that entrapment neuropathies. Okay. H reflex has a sensory afferent, and then it has an efferent, which is motor. Then there is a synapse. Okay. And the nerve studies is a fixed nerve, that is tibial soleus we are checking. You can do it in the femoral also. You have to start from submaximal stimulation and then go to the supramaximal stimulation. The configuration is usually triphasic of H reflex. At low stimulus intensity, H is present without M. As the stimulation increases, H is there, M is there, and at high stimulation, H decreases and M is maximum. Okay. And it can be present in the early polyneuropathies, S1 radiculopathies, GBS, and sciatic and tibial neuropathies. So we come to blink reflex. Can anybody describe the basic pathophysiology of blink reflex?
In the blink reflex is analogous to the corneal reflex.
No, just tell me this anatomy.
Anatomy is V1 supraorbital now is stimulated and response
That is
recorded
first division
and
of trigeminal. This is what is
trigeminal.
so first division of trigeminal, that is
Trigeminal.
V1. Okay, that is getting
And
stimulated. Then
stimulated.
supraorbital,
And,
supratrochlear nerve. Then
response recorded from the
afferent goes.
orbicularis oculi muscle on bilateral.
Correct. Correct.
One is the direct the delay response R2 is from the ipsilateral side, and one is a contralateral from crossing to the medulla.
So blink reflex, first division of trigeminal nerve, that is V1, carries the response afferent, and then its synapses with the main principal sensory nucleus of the fifth cranial nerve in the pons, that is in the mid pons, and nucleus of spinal tract of trigeminal nerve in the medulla. And then what happens from here? To
go from the same side of the 7 nucleus.
Yes.
Produces the ipsilateral R2 response, and second is go to the contralateral side of the 7 nucleus and give the contralateral R2.
Contralateral R2 response.
R2
okay.
response.
Yes, yes, very good. So the earlier R1 potential is mediated by the connection between the main sensory nucleus and ipsilateral facial nucleus.
Yes.
Okay, and later R2 responses are mediated by the multisynaptic pathway between the spinal tract of trigeminal nerve and both ipsilateral and the contralateral facial nuclei. Okay. So first response is by that is R1. It is only one synapse, two synapse, that disynaptic connection between the principal sensory nucleus in the pons and ipsilateral facial nucleus. Okay. And the later R2 response is mediated by multisynaptic pathway between the nucleus of spinal tract to trigeminal nerve and the ipsilateral and contralateral facial nerve. The efferent pathway for both R1 and R2 is mediated by the facial nerve to the orbicularis oculi. That is the anatomy of the blink reflex. Okay.
Yes.
So cranial nerve 5th and 7th, along with their connections in the pons and medulla, they are assessing the blink reflex. Blink reflex is essentially the electrical correlate of the clinically evoked corneal reflex. Okay. Like the H reflex, blink reflex is a true reflex with a sensory afferent and of course motor efferent. Blink reflexes are useful in detecting abnormalities anywhere along the reflex arc, including the peripheral and the central pathways. Okay. You all must have done this blinks response now. For orbicularis, so for the stimulation, it is given at the supraorbital, and then there is this G1 and G2 orbicularis oculi, and you put over here also. Okay, and you need 2-channel nerve conduction machine. Okay, you can't do it on 1 channel only. Then recording is performed simultaneously from both sides using 2-channel recording apparatus. Surface recording electrodes are placed over the inferior orbicularis oculi muscles bilaterally. For recording the CMAP potential from the orbicularis oculi muscle, the active recording electrode is best placed just lateral and inferior to the pupil at the mid position. And the corresponding reference electrodes are placed lateral to the lateral canthus. Yeah, so that is the thing, that when you're putting the recording electrodes, the black should be inside and the red should be outside. That is the thing. So this is the normal blink reflex. Can anybody describe this? And along with the latencies.
Is a normal blink reflex from the right side.
Yes.
First is R1 response. Latency is 11 millisecond. Is
correct.
mostly R1 latency is 13
millisecond. Where is
milliseconds.
the R1 response? No, just me diya hi hai. Okay. So this is the R1 response, right?
Yes, ma'am.
And this is the
Ipsilateral R2 response and
R2. And this is the contralateral R2.
contralateral R2 response.
Yeah. Okay. Then. So you said that the R1 potential is 11 milliseconds and R2 potential is at 34 milliseconds.
34.
R1 potential latency 11 and iska latency is 34 milliseconds.
34.
Ipsilateral we are talking about. Okay. So
Yes,
R1 is usually biphasic or triphasic in potential. Okay. And it is stable from stimuli. All stimuli look same. Okay. R2 potential is variable and it is usually polyphasic. On the contralateral side, only the late R2 response is seen. R1 is usually very small. Okay. In the contralateral side, usually you end up seeing is the R2 only. So R2 potential is seen at the latency of 35 milliseconds. Okay. So you have to superimpose several traces to really record this R2 also. Okay. So what are the normal latencies of R1, R2 and ipsilateral R1, R2 and contralateral R2?
Normal ipsilateral R1 is less than 13 milliseconds.
Okay.
And ipsilateral.
The typical R1, R2 latencies are 10 to 12 milliseconds and 30 to 40. R1 is 10 to 12 and R2 is 30 to 40 milliseconds. And the contralateral is, so this is the actual cutoff value they have given. R1 latency less than 13, ipsilateral R2 less than 41, contralateral R2 less than 44. Okay. The difference between R1 should be less than 1.2 milliseconds, ipsilateral R2 less than 5 and contralateral R2 less than 7 milliseconds. The patterns of abnormality, that this is a normal pattern. What happens in the incomplete trigeminal lesion? So incomplete trigeminal lesion, that is afferent path is affected. So it is going to affect both the contralateral and ipsilateral. Okay. So affected right side, there is delay of all potentials, including ipsilateral R1 and R2, and also of course contralateral R2 also. But if you stimulate it from unaffected side, all responses will be normal. Okay.
Normal.
Then complete right trigeminal lesion will give rise to what? All the stimuli like all R1, R2 and contralateral R2 also are absent from the right side. Okay, but if you give a stimulation on the left side, all if left side ka R1, R2 is coming, but the right side ka R2 is also coming. Okay, understood?
Yes, ma'am.
Then incomplete right facial lesion, that is efferent pathway. So stimulating the affected site results in that is incomplete lesion. Then it will result in delay in the ipsilateral R1 and R2, but normal contralateral R2. This is the basic. Okay. So ipsilateral R1 and ipsilateral R2, there is a delayed latency, but latency of the contralateral R2 remains normal because that side ka facial is normal. Okay. And stimulating the unaffected side, suppose you stimulate on the left side, the ipsilateral R1, R2 will be normal and contralateral R2 will be delayed. So in this pattern, all potentials on the affected side are abnormal regardless of which side is stimulated. Barabar na?
Yes, ma'am.
Yeah. So then complete right facial lesion happens, suppose. Then what is going to happen? So complete right side lesion, affected side result absent R1, R2, contralateral R2 will come. If you stimulate on the unaffected side, normal ipsilateral R1, R2, but contralateral R2 will be absent. Okay. Suppose there is a right mid-pontine lesion. Okay, so what is going to happen in that? Stimulating the affected site results in an absent or delayed R1, but intact ipsilateral and contralateral R2. Why is this happening? Because the connection between the pontine sensory nucleus and facial nucleus is detached. Okay, matlab the afferent is there, but it is not giving conduction to the efferent. Correct?
Yes, ma'am.
So that is why the same-sided R1 is impaired, but intact ipsilateral and contralateral R2 will be there. Okay. Then lesion at the medullary interneurons. Then what happens? Medullary matlab spinal tract of trigeminal nerve, which we saw that polysynaptic pathway, which was there in the medullary area. What is going to happen in that situation?
Contralateral R1. Ipsilateral R1 is delayed.
Both R2 is prolonged.
Normal R1 will be there, so on the same side, but normal R1 and R2, ipsilateral R1 will be normal, and contralateral R2 will be normal, but ipsilateral R2 will be impaired. Understood? How is this happening? So we'll go back to this again, this diagram. Suppose the lesion is at this level. What is going to happen?
Ipsilateral R2 is affected and contralateral R2.
So normal R1 will be there. Okay.
Normal
R1 will be there. Okay.
Yes.
And the contralateral R2 will be normal because it is coming from this, no? Only thing that is affected is ipsilateral R2 because that is being taken care of by this pathway. Okay. Is it clear or not? So from the blink reflex, you can also determine whether it is a demyelinating lesion or if it's an axonal lesion of the whole pathway. Okay, depending on the latencies. Okay. Yeah. So for this session, I have just taken this much of part. In the next session, I'll be taking the nerve conduction like cases. Any other doubt?
Anyhow, any other doubt they can ask in chat box, or
Yes.
they can unmute themselves.
Yes. The H&M ratio should be more than 0.5 in the UMN lesion, less than 0.5 in the UMN lesion. That is what is the significance of that H&M ratio. Okay. That is H reflex and M response. That is the ratio is less than 0.5 in the UMN lesion.
No question. They can.
Somebody has asked the segmental demyelination. I think I described it, that inching method.
Okay.
That is focal demyelination of the nerve. You do a inching method. That is, you give a distal stimulation, then you go for the proximal, but at the proximal level, you can take it at like at least 10 sites divided by 1 centimeters from the below elbow to the above elbow region. Okay, below elbow, at the elbow, and above elbow. Okay, so at 10 sites, you can stimulate by 1 centimeter each. Okay, and wherever is the maximum amplitude drop, at that area, there is a conduction block. That is the focal demyelination. Usually it is used for the entrapment neuropathies or entrapment neuropathies like ulnar neuropathy entrapped at the elbow, or it can be used also for the common peroneal neuropathy.
CTS also.
Yes, CTS also. CMAPs in distal myopathy will be low amplitude. It is any axon loss will be low amplitude. Okay, any motor loss will be giving low amplitude, but the conduction velocity and the latencies will be normal in those cases. Okay.
Okay, if there are no further questions, we can close the session. Thank you, Dr. Swaleha, madam.
Somebody has
It
asked.
was an extensive session for all budding neurophysician, and for future also it will be helpful. You have simplified for all the students.
Yes.
Thank you, Dr. Swaleha, madam, for taking these efforts. If anybody have any questions, they can ask afterwards also. And in the further session, we want more participation from students.
Yes.
We will post the schedule.
Yeah.
Thank you very much. Thank you, Dr. Harshar and Dr. Anusha and Dr. Arpita for participation, and others who tried to answer the question. Thank you, everyone.
Okay.
Thank you, ma'am.
Dr. Ramkrishna will close the session.